JC 24/7.
Welcome to another edition of JC 24/7 as we continue our discussion on cancer, its cause, prevention, and treatment. And today we have invited on set Dr. Marissa Nimrod, a doctor at the National Radiotherapy Center. I got it right, did I? All right. And of course, next to her is a nurse of 28 years experience, and he's also, as far as I know, a pastor. So it's a combination of the medicine and ministry. What a unique combination. Dr. Nimrod, I think I wish to start with you.
Sure.
Are all forms of cancer a death sentence? And whenever people hear the word cancer, they think of what clothes I'm going to be putting on for the casket. Is it true to say that all forms of cancer are a death sentence?
I'd like to counsel my patients and tell them that cancer is pretty much a chronic disease, as in most chronic lifestyle diseases. With that being said, some types of cancers can actually go into remission, which means we reduce the risk for recurrence, where some cases, depending on when they come to me, may actually be best symptom care.
Okay.
So.
Okay. There are how many stages? 3 stages? 4
there are four
stages?
stages.
4 stages. At what stage can we safely say that cancer could be or would be in a, potentially in a state of remission?
I would like to say anywhere from stage 2 down, I dare say 3. So what we do based on the treatment modalities that are given to the patient, we reduce the risk, and we try to follow them up to make sure that it doesn't recur.
For the sake of our audience and for people like myself, could you break down what stage 1, 2, and 3, and 4 looks like?
Okay, so staging pretty much is our international classification to let us know that the extent of disease with respect to the organ of interest. For example, in breast cancer, which is very common, the staging is based on the size of the tumor, the size of the cancer, and how far the cancer has actually spread. Is it still in the particular primary organ? Has it spread somewhere close by? Has it gone further to another organ? So based on those characteristics or criteria, that is how we inform the patients about their staging.
Okay. You did mention the word remission. Could you explain to us what does remission mean, and how should the patient respond to the remission?
So remission pretty much means that a patient is having what we'd like to say a positive response to treatment, in that the cancer, if it's present and the size is there, we notice that it's actually shrinking or decreasing in size. Or for some persons who may not have any cancer visible on a scan after surgery, there's no sign of recurrence at that point in time. So pretty much, it's to take them as close as possible to baseline. So we reduce the opportunity or the possibility for it to pop up again.
Okay. So the person should not rejoice, or should the person?
I mean, we do wish them, congratulations, that you've made a milestone or that you're a survivor. But that doesn't mean that you don't follow up during what we call surveillance to keep track of you.
So you need to follow up.
Yes, you do.
To ensure that the rejoicing is forever.
Yes.
Pastor Murphy, let me bring you in here. Are all forms of cancer life-threatening? I mean, we have different forms. Would you consider?
Well, I think the answer would be yes. Cancer happens to be one of those non-communicable diseases, meaning that you do not receive an infection to get it, so to speak. It falls in the same category, perhaps, in terms of being non-communicable, like high blood pressure, diabetes. All right. You're asking the question if all forms of cancer can be life-threatening, and the answer is yes. If we are careless with our health, if we do not have our regular medical checkups, as we would call them, then the fact remains is that if cancer is present, then the stage can develop from 1 right to 4. And perhaps let me put a plug in now, especially for men. I know we've had a history. It's perhaps a man thing. It's a male thing. It's perhaps our ego. And somebody may argue it is because of testosterone, where we believe that we should not have frequent medical checkup. The truth is that our sisters are much more privileged than we are. For obvious reasons, they are female. They get pregnant, so they land by the doctor, we suppose. We don't get pregnant, I suppose. And because of that, we can't even sometimes accidentally end by the doctor. And so by the time we get there, very often our wives are the ones, or our daughters or sisters are the ones who take us there. And therefore, if I can put a plug in, yes, I answer the question again that all forms of cancer can be life-threatening. But early detection is what is important.
But are some more life-threatening?
Yes, some are more life-threatening.
Do you have any idea of what types we can pinpoint immediately? What comes to mind?
You want to just answer that one?
Okay,
yes.
So lung cancer, small cell in particular, by the time you find out that you actually have that particular type of, it's normally far gone by the time we pick it up. A type of thyroid cancer called anaplastic, in terms of the type of cells, that's another one that moves pretty quickly, and by the time we find it, it's a little too late. And also in pancreatic cancer, by the time we find it, especially if it's at the tail where it's not causing any obstruction, you know, so that the eyes go yellow, you look jaundiced, etc. Sometimes you don't pick up on it. You know, those are some that actually present, and sometimes it's a little bit too far out.
You mentioned earlier about breast cancer. Are some cancers gender biased?
Oh, yeah, definitely. Anatomically, as you said, for one. So, you know, but men get breast cancer too, by the way, right? So, I would probably say yes to some degree. Off the top of my head, I really can't put any in particular that has a gender bias recently. So, because we've had, you know, just as much numbers of male and female patients, you know, presenting with colon or colorectal or, you know, so it would really be, you know, breast versus prostate versus, you know.
So again, amongst the men, prostate is the most prevalent. Would you agree? Why is that so? Do you have an idea?
Well, we know that as we grow older, there's a tendency for the prostate gland to become a little enlarged as we grow older. Because of where it is again, anatomically. In addition to that, it goes back to my argument earlier on that says that because men generally do not attend for medical checkups and so on, then by the time the diagnosis is made, it might very well be late in the night. And late in the night here is figurative.
I hear you.
And sometimes it may very well be late in the night.
I hear you as well.
So yes, we've got that. We do not have uterus, so we are not going to come down with uterine cancer. We do not have ovaries, so we are not going to come down with ovarian cancers. But like Doctor has said, all the other forms of cancers, whether they affect the pancreas, they affect the lungs, they affect the breast. Yes, because men, you know, it's correct, men, we do suffer with breast cancer as well.
All men susceptible to prostate cancer, or does it have a preference for certain types of men, race, ethnicity, etc.?
Well, the data suggests that African American men and African Caribbean men, and I suppose we can break it down, African Trinidadian men and African Tobagonian men, right? It does not include it does not exclude the other races. But there is a tendency to see it amongst those of us of African origin more predominant than the other races.
Do you have any data to support why that happens?
Well, according to the 2010 American Cancer Society guidelines, they didn't have, per se, a particular cause or etiology for it, apart from what you would call observational data in terms of the ethnicity for the men who present. But I don't think there's any genetic concrete evidence, you know, that I can see since I've done my research before coming. All right, so you know, we screen pretty much along those lines, and as Pastor said before, yes, the other ethnicities do get it, but their risk is lower, probably 7%, where it may be, you know, 20% and above, you know, for persons who have...
Pastor, you did mention that as men get older, what age are men beginning to get susceptible to prostate cancer?
Well, the benchmark is age 50. But we are now seeing men who are in their 40s and even some in their 30s who are now developing prostate cancer. The truth is that once one discovers that there has been a history of any form of cancer in the family, then the recommendation is that one must at a much younger age seek medical review simply to check and to double check to ensure that some form of cancer is not developing. The very fact that men, we have a prostate means that that's one of the primary organs that you want to guard, as it were.
Okay.
Yeah.
You mentioned that if it's in the family, so are we saying that cancer could be hereditary?
Yes, it can be. We have more than a preponderance of evidence to suggest.
Okay.
Yeah.
What do men do, Pastor, to prevent the onslaught, if you like, of prostate cancer? What can a man do?
Well, one of the first things that men we need to do, we need to, again, have a regular medical checkup. We need to begin to look for symptoms, even though the literature will tell you, and the experience that we have will say, that sometimes prostate cancer, the person who suffers with prostate cancer might be asymptomatic, meaning that there are no symptoms. However, there are some telltale signs. Frequency of micturition, that is frequency of passing urine. We have blood in the urine. We also have semen in the urine. These are signs.
Okay.
Not only that, but sometimes we have difficulty micturating or difficulty voiding the bladder, because where the prostate gland is located, the prostate gland surrounds the urethra, which is the passage through which urine and semen is voided to the outside.
Right.
And therefore, if it becomes enlarged, secondary perhaps to prostate cancer, then naturally it's going to cause the line or the urethra, the passage through which the urine and the semen would pass, to become occluded or blocked, and therefore you may very well observe as a man that you're about to void your bladder, and we would have seen this all the time. There are times you think that a man has completed voiding his bladder, and when you look, you recognize that he hasn't started as yet. In other words, if it's taking a long while, if something is creating the jam, then you really need to go and find out what is. The problem with us as Caribbean peoples and Trinidadians and Tobagoans, we always have somebody in the village who can boil something for you, right? In Tobago, I'm told it's Pacro water. I don't know what it is in Trinidad.
You're from Tobago,
right? You know, but there is always somebody who can, in the village, who can come up with a concoction.
Right.
These are contemporary times. These are modern times where modern medicine is available. Okay. And we have seen too many persons dying from prostate cancer. I have buried too many men.
Oh.
And we need to talk about that as difficult as it might be to talk about it. I've buried them who would have died secondary to prostate cancer. The reality is, if these guys were not careless and indifferent with their own health, they may have been alive for today. These are telltale signs that something isn't right, and therefore you want to go to your doctor to ensure, one, that if there is something that's developing, then they can nip it in the bud very early, and if it is something that is treatable, it can be treated. But more than that, you have a sense as to what's happening. And perhaps that may take us again into one of the examinations to tell a man that, hey, something isn't right. The prostate gland is about the size of a walnut. Okay. Not large, it's small. And so there is what is called a DRE, digital rectal examination. Where
the infamous.
Oh, yes.
DRE.
Where a doctor puts a glove on his or her hand and inserts the finger into the rectum, because the prostate gland is just underneath the urinary bladder, and therefore it's very, very easy for the doctor to feel the prostate gland. And because he or she knows that it's the size of a walnut, if when the finger goes in, it's the size of a small orange, then you know that something is not right. And worse than that, if it's the size of a grapefruit, then you know it can't be big. Right. Yes, it can get large. Okay. And therefore, in those circumstances, the doctor is able to pick up that something is not right. Okay. And therefore, he may or she may order another examination, maybe a blood test, PSA, which is a prostate specific.
For the benefit of some of the men who are already squirming with discomfort, is that the only way of testing the prostate? Well,
no. Well, of course, you got digital rectal examination, which is using the finger, so the doctor can feel what's happening. Right. You also have the PSA, which is a prostate-specific antigen test, which is a blood test. All right, and of course, based on the results, your doctor will be able to tell you whether, in fact, that cancer is developing, and perhaps how bad or how gloomy the picture might be, if it is at all gloomy.
Okay, you're making me very discomfort. We have to take a break at this point and come back as we continue our discussion on cancer as it relates specifically to our men.
JC 24/7.
How many hairs do we have? It numbers close to 20 million. Most body hairs are almost too small to notice, but they can be helpful. If a biting insect like a flea or mosquito lands on the skin, it pushes the hairs. Sensitive nerves around the base of each hair detect its movements and warn us to get rid of the pest. All through life, each hair has its own growing cycle. For example, a scalp hair on the head grows for up to 5 years and then falls out naturally. After a few months, another hair begins to grow from the same follicle. This happens all over the scalp, all the time. So although 100 or so hairs fall out daily, another 100 are starting to grow again. An eyebrow or eyelash hair lasts for only 10 weeks. Hairs on the head grow about 12 millimeters each month, although fine, fair hair grows more slowly than thick, dark hair.
JC 24/7.
Welcome back to our discussion on cancer, its cause, prevention, and treatment. And we're looking specifically on prostate cancer. And when we took the break, or just before we took the break, Pastor Murphy had some of our men in a bit of discomfort. And I want to go back in this time to Dr. Marissa Nimrod. Could you please tell us why is it so important for men to have the testing? And is it important at all?
It is actually. And what has happened is that in previous years, probably from 1998 backwards, the mortality rates or the death rates were probably higher. Mm-hmm. But now we've implemented things like screening tests, mm-hmm. as we said, the PSA blood test and the DRE, digital rectal exam. It's actually led to an improvement in overall mortality. So we don't have a lot of men dying from it, and we have people living up to 90-something, as one of my clients.
Okay, okay. What are some of the major contributors to the spread of cancer? I mean, we are told it's a lifestyle disease, is it? Right. What are some of the contributors? I know we maybe want to talk about diet and lack of exercise. Could you maybe educate us a little bit as to what are some of the major contributors to the spread of cancer?
Well, if I could probably just deal on just one little aspect of it. We know that it has a lot to do with our diet, and therefore there are some foods that the recommendation is that we do not eat too much of them, and I'm saying eat too much of them, or don't eat them at all. Mm-hmm. We know that red meat is implicated, or that we know. Oh, yes, we know that for a fact. We know, for example, smoking. Okay. That might not be that, but that's lifestyle, that's habit. Okay. Smoking, and not only breast cancer, but other forms of cancer as well. So we know smoking is also fingered, and therefore we say to the national community to avoid smoking. And if I'm to sound pastoral, I would say don't smoke at all, right? And whatever we do, we must do it in moderation, yes. Right. But we know for a fact that certain kinds of foods make the patient high risk. Okay. And I repeat again, red meat, for example.
What about red meat? Right. That causes the spread or promotes the spread of cancer.
Well, I suppose whatever is in red meat to start with. Right. It's a much more difficult meat to digest. We know. Fish and chicken is much easier to digest. So it's easier on the stomach and it's easier on the alimentary canal or the gastrointestinal tract. Right. So we also know that anything that has to stay too long in the stomach will be digested. Okay. Then you may want to revisit what your diet or your dietary regime is like. So we know that for a fact.
Dr. Nimrod, you heard anything about asbestos and stuff like that will also promote the spread of cancer?
Certain risk factors obviously are related to certain types of cancer. So asbestosis is related to lung, inhalation, sets you up. Won't go into the details, but yes, asbestosis can be in association with lung. You said smoking. Smoking can go with bladder cancer. Alcohol, alcohol. Quite a few head and neck, throat cancers. Same thing, bladder cancer. So you do have risk factors that are associated with certain types of cancer.
Is the non-smoker who inhales smoke also at risk?
Yes, they are.
Secondary smoke.
Why is that?
Secondary smoke.
But I tell you what, very simple for John Public, and that is the person who smokes at the end of the cigarette or at the beginning of it, whatever you want to use as the end or the beginning, there is a filter. Okay. So he pulls the smoke in. Right. He inhales the thing in through his mouth and obviously through his pharynx thereafter. Right. So he has a filter. for the person who we consider to be receiving the secondhand smoke is somebody who sits around in a room, doesn't have the benefit of a filter to start with. So he inhales and exhales all the time, and therefore he's pulling the smoke, he's pulling all the tar, he's pulling everything into the lungs. And therefore, that's the reason why I think the government has gone on a very aggressive program in terms of ensuring, or at least trying to ensure, that smoking is prohibited in public places, schools and hospitals and so on, because the ministry also knows of the risk involved in people who just sit around or lie around and inhale all of that smoke.
Dr. Nimmer, do you know of any myths surrounding cancer that you have had to treat with in your experience that comes to mind immediately?
I don't think I've had that much in terms of myths, apart from people's perception of alternative cures, as Pastor had said before. So certain types of plants or herbal remedies, or may be associated with, a particular cure. I normally practice evidence-based medicine, so I would, to say on the side of caution, to say I know that what we give in terms of treatment has a particular expected effect. That doesn't say I don't believe in herbs and therapy, but there's certain things that people come and you hear them discuss. If you take this, it will do that. There's no scientific link to it as far as we know at the moment.
And I suppose another myth is a diagnosis of cancer is a death sentence. That is a myth.
That's a myth,
because we hear it all the time. I grew up on that, hearing that. Well, it's cancer the woman has, so she'll die just now. And of course, the jury is always out on that. And it's not because somebody has received a diagnosis of cancer means that the person will die. Modern medicine, thank God for His grace, and thank God for the research that has happened over time. Let me use the term that doctor has used, evidence-based. Treatment is available, and certainly in some cancers, there is that curative aspect of it. So it's not about throwing your hands up. It's not about writing your will. It is not about calling your family in because you receive a diagnosis of cancer. Of course, a diagnosis of cancer, like a diagnosis of anything, is going to hurt. But rather than throw one hand up in despair, is let's look at what the diagnosis is. What are the treatments that are available? And based on the counsel I've gotten from my physician, and of course getting my family involved, because you can't go through this alone. No man is an island. And once you have good friend and family support, or even support in the church, because for some people the church is the only family that they have, then our positive outlook at a diagnosis even of cancer can really change what the prognosis is going to be.
Have you ever met somebody who's cynical, who has said to you, well, Pastor or Doc, I'm going to die anyway. Why should I be careful about what I eat and what I drink? We're all going to die somehow. Some may go through drowning, others through an accident, a freak accident. I may go through disease. Why are you trying to get me so concerned about what I eat? What kind of response have you actually been able to give to a person like that?
Well, for those of us who are into clinical practice one way or the other, those of us who work on the wards as nurses, those who are physicians, and I think more so, and this is not to take anything away from doctor, but more so nurses who are out there on the ward 24/7. There is nothing that you miss or misses you on the ward. And I think the pain comes when you see your patient writing in anguish and pain. And it's very easy to talk when the symptoms are not there. But when the symptoms come, and when the pains are generalized, and when the analgesics or the pain relieving agents are not providing the therapeutic value for the patient, then what you've been trying to say up front really makes quite a lot of sense. So I want to urge folks not to be careless with what you eat, not to be careless by smoking, not to live a careless lifestyle and a carefree lifestyle. Yes, we all have to die, but we do not all have to die a particular way. We do not have to die in pain. Thank God there is the aspect of cancer treatment now palliative, where you want to give the patient the best quality of life, even though he might be end stage, or even though he or she is going to die. But even that sometimes is fraught with its own amount of difficulties.
Right.
Nobody wants to see a mother on the bed crying, or suffering, as we would say. Nobody wants to see or a relative, or by extension, nobody wants to see a human being suffering. Even your enemy doesn't bring any kind of joy and comfort to your enemy, or to seeing your enemy on the bed.
That's right.
As the language is there in pain.
That's right.
And therefore, for the persons, and I did have the experience already. I remember there was this one lady some time ago who says, well, all of us have to dead. And it really matters not what takes you out.
Right.
Of course it matters what takes you out. Right.
What's the role of prayer, Doc? Because I'm sure you may have had to tell some of your patients, I think all that you need right now is to pray, or pray that the person gets out of this situation. What role does prayer play in the whole process of cancer treatment, if you like?
Well, I counsel my patients. I tell them that man is both physical, spiritual, mental, he's a whole package. So treating the body is part of it. But, if you fulfill the other components and you have a hope, then that obviously, makes the journey even easier.
Okay.
So in that case, we have quite a few people who actually seek the calming peace of mind that prayer actually affords, and they have this relationship with God. And you hear them, talk to others and tell them about the joy that they get, in spite of their infirmities or the disease, and I think that completes it. So apart from the counseling and the psychiatrist to take them out of depression, prayer is something, that works even better to get them to that place, in terms of a happy or normal state, and take them through the rest of their treatment.
Beautiful. And Pastor?
Just I'd find what Doctor has said, and that is, we know for a certainty that cancer loves a stressful environment. In fact, the cancer cells are going to proliferate.
Okay.
And therefore, for the person who is at peace with himself, at peace with his God, and I'm simply commenting on the spirituality aspect of it, here is a person who has done himself a world of good by having, some people would call him a higher power. We believe him to be God, knowing that God can intervene. And yes, it is not that I'm asking folks to be complacent, but I also believe that the power of prayer can still work miracles. And this is not to say not to comply with treatment regimen, but in addition to complying with your treatment regimen, know that there's a God who is even greater than all of this.
Beautiful. Let me sort of ask you to switch hats now from being a nurse to a pastor. God did not intervene. The person has prayed, and the person died.
Okay.
What do you say to the person? Now, closing few minutes here we have here.
Well, it's not limited to cancer. And truth be told, I know this might shock some people, but if this world was to last long enough, then none of us will get out of it alive.
Okay.
So it's not limited to cancer.
Right.
But because we're treating with the issue of cancer, just let me say this. There are some diseases, some disease conditions, some disorders that may not go into remission and would have a natural progression to death. What matters for me in life is not just what you die from, and even how you die. It's who you die in or who you die with. I have a hope that burns within my heart. Hope in the coming of the Lord. I believe that we are only pilgrims passing through. Granted, we are here for a very short period of time. It was just the other day I was a little boy in a little country village. I'm now realizing that I'm heading closer to my retirement.
Have mercy.
And that was just the other day. And then after that comes death, or before. Or before.
That's right.
And therefore, it is important for me to say, if you've received a diagnosis of cancer and the cancer is not responding to treatment, the cancer has metastasized, you are now in the final stage or the fourth stage of cancer, it is still not one that one should feel a sense of hopelessness or worthlessness. Because my worldview says that I'm only passing through, and there is a better life after this life if I am faithful to my God. Then even though death might be what is anticipated, I can embrace even death just as a sleep, knowing based on my Christian belief and my worldview that after death, there's a God who can change these vile mortal bodies from mortality into immortality.
Pastor, I want to thank you so much for joining us today. And Dr. Marissa Nimrod, we also thank you for your input. I'm sure we could have spoken a lot more about cancer, but suffice it to say, I think we can sum it up this way. Get wise. That means, exercise, eat the right foods, get tested. Make sure you go to your doctors. Men, listen, go to your doctors. And finally, get close to God. You will need him in times like that. Thank you for joining us today, and we look forward to having you back with us on JC 24/7.